Today, we will discuss trigeminal neuralgia. Trigeminal neuralgia is characterized by unilateral paroxysmal facial pain. The pain is triggered by trivial stimuli like a breeze or by drinking water. The pain is severe. It is described as lancelating and electric shock-like. The pain lasts for a few seconds, after which it subsides. The pain is so severe that trigeminal neuralgia has been described as suicide disease. The intervals in between attacks of pain may be totally pain-free. The distribution of pain is along the distribution of the trigeminal nerve. V2 and V3 segments are most often affected. Trigeminal neuralgia is caused by a demyelination of the trigeminal nerve. The demyelination occurs in the transition zone between central and peripheral myelin. The causes of demyelination are neurovascular confrontation, tumors, and also demyelinating diseases. Classical trigeminal neuralgia is associated with neurovascular conflict. An artery is in contact with the nerve, and demyelination occurs as the arterial pulsations continue. Commonly, neurovascular conflict is arterial. The superior cerebellar artery or its branches are involved. ICA, or the anterior inferior cerebellar artery, may occasionally be the culprit. Venous conflict is suspected when arterial conflict is not demonstrable. Initial management of trigeminal neuralgia is by pharmaceutical methods. Carbamazepine and oxcarbazine are common first-line drugs. Pregabalin and gabapentin have a role. Destructive procedures can be used for relief from trigeminal neuralgia. These include radiofrequency ablations, chemoneurolysis, that is alcohol or other toxic injections into the nerve, or gamma knife, where the trigeminal nerve is targeted near its root entry zone by gamma knife. Surgical management is definitive, and it is described as microvascular decompression. A few notes about how microvascular decompression is performed. Patient is often placed in the lateral position. A CT angle approach is used. A small craniectomy is done at the junction between the transverse sinus and the sigmoid sinus. The dural opening, there are different techniques. The most elegant is by leaving a 2 millimeter rim of dura close to the sinus. CSF drainage is usually done initially to facilitate cerebellar retraction without retraction. Landmarks that we see, the seventh cranial nerve usually comes into view first. Superior to that, as we go towards the petrotentorial junction, we see the superior petrosal vein. The fifth nerve is usually visible by now or becomes visible with a modem of arachnoid dissection. The fifth nerve is traced from the pons to the exit. A loop of superior cerebellar artery is often seen in the axilla of the nerve. Surgical treatment or microvascular decompression involves the interposition of Teflon or fascia between the nerve and the artery. This is simple. Some surgeons try to do arterial transposition, which is a very elegant procedure where a loop is used to transpose the artery and probably hitch it to the tentorium. Having a quick overview, trigeminal neuralgia affects the older age groups. It is characterized by paroxysmal severe facial pain. The pain occurs along branches of the fifth cranial nerve, often affecting V2, V3 segments. Classical trigeminal neuralgia is because of neurovascular confrontation, usually arterial, occasionally venous. Other causes of trigeminal neuralgia include tumors and demyelination. Management is initially by drugs. Oxcarbazepine or carbamazepine are the first choice. Nerve ablations can be done by radiofrequency, by neurolysis, or by gamma knife. Surgical management is definitive and involves microvascular decompression, that is, an interposition of a cushion between the artery and the nerve.